Welcome to a CME podcast episode from NEI, the Neuroscience Education Institute, hosted by Dr. Andrew Cutler. For complete CME information, please refer to this podcast's description page or go to nei.global/podcast.
Hello and welcome to another NEI podcast. Now, this one is a CME podcast, so you can get educational credit. And with me today, my good friend, Dr. Christoph Correll. Christoph, how are you?
I'm well. Thanks, Andy, for having me. I really look forward to our discussion today.
Me as well. And, we're talking about something that is a very hot topic, and that's bipolar disorder. We have some treatments FDA approved, but we've learned a lot about this illness, and I think it'll be interesting to talk about kind of the patients we don't necessarily see in the clinical trials that you and I have been involved with. The real-world patients, more complicated, complex patients. So let's start out just with one thing, which is, I think, the key to bipolar is to recognize it, right? We need to have a high suspicion of bipolar in any depressed patient. Would you agree?
Absolutely. I mean, the problem is that either people who are currently diagnosed with unipolar depression might be at risk for and develop mania in the future. And that's something that you should always be on guard for and ask patients, even though you think, oh, this is just my usual depressed patients, or they come in having depression and you're not even assessing that they already had either a hypomanic or manic episode, because these patients come in, dark-colored glasses, everything is bad. They only remember the depression. They can't remember that they were doing well anymore. And sometimes we feel, they're talking about these high times. Maybe they just remember normalcy. Exactly. So as you said, we have to bear it in mind and actually probe and not be lulled into this, depression is depression.
Yeah. If we're honest with each other, Christoph, and you and I are always honest with each other, who wouldn't want more energy? Who wouldn't want more confidence? Who wouldn't want to need less sleep and get more done? So that, as you said, they may identify that as the goal, is what I want to be like, not as something abnormal. So obviously we have to look. What also can complicate this, of course, is that, as you said, maybe we do ask about a history of mania or hypomania. Patients are not great at reporting that. But what about asking about current manic or hypomanic symptoms, which we call, of course, mixed features or mixed states?
Yeah, let me go there in a minute. I just want to go back to what you said, past or even present, because I thought you were going, some complicating feature can be comorbidities. So there can be agitated depression with anxiety. What about substance use? What about personality disorders that are in the mix? Trauma in the past. So you have to really dissect this, because there are these overlapping symptoms and syndromes in order to understand the patient better. I think some people have said, if you can treat bipolar disorder well, you can treat almost everything in psychiatry because of all of these comorbidities. And it's the up and the down. There can be psychosis, many, many things. And to recognize it is to think about it. And actually what has given the bipolar disorder recognition a boost was this self-report, the mood disorder questionnaire or the rapid mood screener, where we allow the patient to reflect on certain symptoms. They're really pointed to them and come in, and then we see, there are a couple of high points that I hadn't even thought about, and then we can explore this. But what you mentioned is also this overlap between mania-like symptoms and depression-like symptoms. And let's face it, until DSM-5, we had a very bucketed view of bipolar disorder. You either have mania or depression, or you have both at the high point. Well, but let's face it, life is dimensional. So what about depression with some intermixture of mania symptoms, or the other way around? And what we've learned is that this is actually more common, and it's more complex and complicated.
Yeah, all well said. And I want to just highlight what you said there, that the vast majority of bipolar patients have comorbidity. They have something else, both psychiatric and medical. And our good friend Roger McIntyre has published a lot about some of the medical comorbidities, the obesity, cardiovascular disease, diabetes, even migraine headaches, of all things. So you're right, that really complicates both the evaluation and the treatment, I would say. And some of the things you said, too, are helpful clues: an anxious, agitated depression. And I completely agree. As someone who's done clinical trials for 30 years, I remember the DSM-4 mixed episode, which was hard. You had to meet full criteria for mania and full criteria for depression at the same time for a certain period of time. And that's just not how they present. As you said, it's more of a dimensional. They usually present with more of a predominant mood episode with features sprinkled in from the other pole. And so we can't turn our brain off when you see a depressed patient. You still have to ask, not only in the past, but recently, have you had any of these things? And Roger's published something I find very helpful, which is the 4 A's, of course, when you see a depressed patient with anxiety, agitation, anger/irritability, attentional problems, distractibility, trouble concentrating, and so on. That's highly suggestive of a mixed state, or mixed features, I should say. And while that does not by itself diagnose bipolar, it sure makes it likely this is somebody in the bipolar spectrum, if you will, and changes the way we should think about treatment. Those are patients who should not get a traditional SSRI reuptake inhibiting antidepressant as monotherapy. Those are people who need a second generation or atypical antipsychotic with proven efficacy for depressed states. Yeah.
Or also mood stabilizers.
Yes,
and that's
or
like
both.
valproic acid or lithium or both. And that's the point here. We need to guard against future mania and depression. We need to treat current manic and depressive symptoms. And one drug most likely can't do it all. So it's a combination not only of disorders and symptoms and syndromes, but also a combination of treatments. We need to select carefully, understand from the past what has worked. While it may not have worked in monotherapy, it could have improved the patient somewhat. May we reconsider it? What are drug-drug interactions? What are side effects that could be synergistic or even additive? And how do we assess this? And we'll talk about this later, to make the patient better equipped to achieve their goals, and that's both symptom stability, but also side effects that don't interfere with functioning.
Yeah, you just made me think of something. It may be almost too much to ask of one medication to do all those things, to treat acute depression, acute mania, and maintenance, preventing relapse. And this is probably partly why people end up on so many different medications. The vast majority of patients are on more than one medicine, either to try to address the complications of bipolar or, as we said, the comorbidities. So this makes it complicated, obviously.
Absolutely, yes. Yeah. But we have agents available for mania. It's all these treatments that can also treat psychosis, because we believe maybe there's a dopamine storm in some areas of the brain that gives you psychosis, and in other areas, psychosis with mania, or mania with psychosis, or mania without. And so we have more drugs actually from above than from below, because depression can be treated, but antidepressants can also kick people into mania. Although even that has been now questioned a little bit. With the right sheltering or shielding from above, you might carefully, in some patients, introduce antidepressants, but only with that shield to prevent then a recurrence of depression. But we do have some agents, antipsychotics, that are better for depression than others. And we have also some of the mood stabilizers, lamotrigine is one of them, obviously, that is predominantly good for depression. But here, Eduard Viatat and his group has actually introduced the idea of the polarity index, because we've talked about, what about the future? What can we expect? Now, we do know from longitudinal studies that in people with bipolar II disorder, it's a 30 times greater likelihood to have depressive symptoms than hypomanic symptoms. And even in bipolar I disorder, depression predominates. But we have subtypes. Some are more on the mania side, some are more on the depression side. And if you look longitudinally, lifetime-wise, you may know where you have to put your emphasis for this patient.
Yeah. I love this conceptualization you're talking about. I first heard this from Terry Ketter, stabilizing mood from above versus stabilizing mood from below. Most of our bipolar drugs are better at stabilizing from above, but we have lamotrigine, as you said, and some of the atypicals. And I'm fond of saying recently, I don't know if you've heard me say this, Christoph, all antipsychotics are antipsychotic, duh, but they're not all antidepressants. And it seems some have stronger antidepressant signals than others. So
absolutely. And this, is predictable. The more dopamine blockade you have that's isolated, the less antidepressant agents are, because you can actually, with too much dopamine blockade, cause some secondary dysphoria or even dysthymia. And we need some serotonergic tone that is being modulated. So 5-HT7 is relevant here. We have, for example, lurasidone, but also the partial agonists are helpful because they are 5-HT1A partial agonism, but also D2 partial agonism. And then now lumateperone also has this partial agent, or the inbuilt SSRI, and also some D1 related NMDA receptor modulation. And that's where we have other antidepressant action now that is helpful. So we need to know a little bit about that. We know it obviously from the approval for certain disorders, but it's interesting, many of these second generation antipsychotics, when used for bipolar depression, you need to dose them lower, because if you go high, like for psychosis, again, there's too much dopamine blockade, maybe the exception being, again, lumateperone.
Yeah, which is not a very potent D2 blocker, you're right. And then, of course, let's not forget cariprazine with the D3 story.
Absolutely.
Although it also
Yes.
has high affinity for 5-HT2B, which is very much an antidepressant mechanism too. So I guess what we're saying is they all seem to work on D2 somehow, but then beyond that, there's a lot of variability, and this may
Yes.
account for why some are more antidepressant than others. But it also makes me think of how important it is to individualize.
Absolutely.
Not only the choice of this medicine, but even the other medicines you might add to it. And that's part of what we need to talk about, of course, is how should we think about the complex regimens and balancing efficacy, side effects, and drug-drug interactions?
Absolutely. And I think here, again, asking the patient what has worked, what has not worked, which side effects were particularly bothersome with either individual agents or that they don't want in their life. Are they more sensitive to sedation? Do they like sedation at night because they are poor sleepers? Do they have problems with weight gain? What about sexual side effects, restlessness? So finding out what the patient's goals are, not just in life or to improve symptoms, but also to avoid certain side effects. And then bonding with the patient, saying, okay, if they happen, usually side effects can be managed. Weight gain is a little bit something that's harder to manage because it accumulates. So here, early weight gain predicts later weight gain. We may want to adjust our treatment plan accordingly, particularly if a drug that causes weight gain is maybe the only one that has given very robust efficacy for certain symptoms. And we know that, for example, olanzapine can be in that camp, not only for schizophrenia, but also for some people with either schizoaffective disorder, bipolar type, or even with bipolar disorder, that this coverage from above for some patients requires olanzapine, and then we have to manage the weight gain and the sedation.
Yeah. That's an excellent point, talking about, first of all, let me just echo something you said that we don't talk about enough, which is something I've been doing for a long time, and that is asking the patient what side effects are most troubling to them, because we can't assume that everybody's bothered to the same degree. I've had patients, for instance, say, whatever you do, Dr. Correll, don't give me nausea, Well, that's going to affect my choice of the medicine. So I love what you're saying there about understanding the patient, and then, of course, understanding what concomitant medical conditions they already have. Are they diabetic, for instance, obese, cardiovascular disease? What other medicines are they taking, not just for psychiatry, but for general medical conditions? It could be an issue. So I love all those. I want to focus in, though. You mentioned olanzapine, which is just an incredibly effective medicine, and it really works fast. And I can tell you that for years had been my go-to acute mania drug. But now, let's say you get somebody through that mania, and especially if they have, which most people with bipolar have some degree of pre-existing overweight or cardiovascular, what do I do now? Well, I've got them through the acute phase. What would I do now to try to manage the weight gain, prevent the weight gain, deal with it? How do I do that?
Well, first of all, I think you need to monitor it. Because,
very good.
We know that early weight gain predicts later weight gain quite a bit. And there's also the metabolic abnormality, either glucose or lipids, that may go along with weight gain, but can even be independent of weight gain because there's a weight-independent effect that olanzapine can have. So let's monitor it and then see, well, is this only olanzapine that has worked, or could we potentially switch? But if that has not worked with other medications, then maybe we don't want to give up that stability. And now we have to have a long-term management plan to counter, mitigate, or reduce some of the cardiometabolic burden. Now, obviously, the initial one as well. What about healthy lifestyle? Well, it's easier said than done for all of us. And then when you have an illness, a mental illness, it may be harder. But yes, you want to teach people about diet, exercise, that with olanzapine, your satiety signaling is delayed. So stop eating while you're still a little hungry because that satiety signal will kick in. Also chew more and swallow less. So basically the calories are counted not based on what you swallow. Even if you have a thicker soup, the next meal with the same calories will be lower than when you have a thin soup. So we want to have them chew a lot. And these high carbohydrate snacks and everything, no sugared beverages. Even if it's 0 calories, but it's sugared in your drink, the 0 calorie sweetened drinks, your next meal will be larger as if you hadn't only water and no sweetened drink, because sweetness triggers insulin. Our brain doesn't know or the tongue and the brain don't know that this sweetness doesn't have carbohydrates. For millions of years, the sweetness was always carbohydrates. So in that sense, yes, we can change that. You don't want to sit too much only behind the screen, have some activity, exercise, and maybe with people. Group exercise is easier. Somebody actually gets you and say, let's walk outside. But once we've done that, and this has worked to a degree, there can still be this increased appetite and more weight gain that ensues. So here we either then have another pharmacologic treatment, and we could add metformin that has not been as potent as, for example, GLP-1 agonist, liraglutide, semaglutide, but not everybody has access to it. They may not have yet the cardiometabolic burden that is needed. We want to prevent the weight gain. So here then is the question, if olanzapine is the ingredient that works so well, what about an olanzapine version that has somewhat less weight gain potential, at least in the future less weight gain? And that's a drug that's now available to us. That's olanzapine plus the mu opioid-preferring antagonist, samidorphan. And this combination can have the same stability in terms of both schizophrenia but also bipolar disorder, bipolar 1 disorder, for mania prevention and treatment, but it has clearly less weight gain. It's not zero, but it is less.
It's not zero. Yeah, I want to highlight a couple things you said and then build back to the olanzapine samidorphan. Metformin, my understanding is, though, needs to be started kind of right away. It's better at preventing weight gain than taking it off. GLP-1s are very effective at taking it off, but as you said, there's all kinds of challenges with access and whatnot. But this newer olanzapine samidorphan combination, what their data showed is the first 4 to 6 weeks, you might see some weight gain, but then there's this incredible mitigation effect. It just flattens out over time, which is certainly not what olanzapine alone does. If you're one of the people who gains weight with it, it just keeps on going. So I like that suggestion. That makes a lot of sense. Now, why is it so important that we assess for these mixed features? What are some of the predictors or some of the differentiators that mixed features predict bad things? What kinds of worse things does someone who has the mixed features going to experience?
Yeah, so there are two ways of thinking about it. Maybe mixed features are just bad or worse for outcomes than purer symptoms because our treatments are not as good as treating them. Or is it because it's a marker of more instability in the brain? You can't hold basically one episode alone. It bleeds into each other. And we have seen that people with mixed features, which is either, just to repeat it, depression, fulfilling all criteria for depression, with sprinkled in symptoms of mania without the ones that are just non-specific, like psychomotor agitation or concentration difficulties, but the other ones. And then vice versa, having mania and not pure mania, but also sprinkled in depressive symptoms. And we know that patients are more treatment resistant. Our treatments are not as good for these patients. And there's actually also, with this agitated depression or the depressed mania, you have more suicidality. People are more likely to be disinhibited and then hurt themselves because they do things without having good judgment.
Yeah, mixed features definitely predicts worse outcomes. You know what else? Rogers published on this too. Mixed states predict more comorbidities, both, again, psychiatric and medical, which is what's so interesting here. So I guess we really do have to be mindful of that. And again, that's a patient where you're going to be much less likely to want to use a traditional, what I call non-mood stabilizing antidepressant, reuptake inhibitors and such. Yeah. Okay. So we talked a lot about that. I don't think we talked enough yet about drug-drug interactions. Of course, that's something we really need to clue into. And Christoph, I learned something years ago. A patient taught me this. I call it the shopping bag trick. I have a patient fill up a shopping bag with every pill bottle in their house. And honestly, it's not enough to ask them what other medicines you're taking. They may not remember. You will find amazing things. There'll be bottles from other prescribers you didn't know they were even taking. You'll find, as I found one time, this is an interesting but sad story, A woman was taking both a bottle labeled benztropine and another one labeled cogentin. She didn't know they were the same thing, and she was wondering why she was sedated. And so I was able to fix that pretty quickly. So I find cleaning that up, and a lot of times people seem to add medicines more likely than to take them away. So I think that's something else we have to talk about, is that cleaning up things sometimes can be effective and helpful. Yeah.
Absolutely. I think we make often the mistake of, okay, there's a little bit of improvement, but we need something else. Rather than switching, we add. And then if a patient improves, we don't complete the switch. Maybe the improvement is due to the new drug and not the interaction between something that didn't work so well and something that was reintroduced. So cleaning up our act is important, but I think it's also important to set the expectation with the patient. Because if the patient experiences, you put the two together, now I'm better, I don't want to rock the boat, rather than saying, okay, this doesn't seem to work well for you. Why don't we put something on? And if it does work, let's try to take this off that has given you some side effects and may not have worked. If it's only working together, we'll establish that. But getting the patient to think what's the next step is, I think, very important.
Yeah, I completely agree with you. I mean, obviously, we can't always be purist. Obviously, monotherapy or less polypharmacy is better. But again, let's face it, a lot of times we have to use more than one medication. And if it's done thoughtfully, I think polypharmacy can be rational and reasonable. We've all had those cases where, you just needed to get a certain combination and that was it, got the patient stable. So I don't question colleagues. I don't question always the regimens, but yeah.
And I think especially, as you said initially, in bipolar disorder, polypharmacy is the name of the game, and it's evidence-based. It's different than schizophrenia. Two antipsychotics or antipsychotics with other drugs, we don't have good data, although people do it left and right. But in bipolar disorder, it's clear. Adding an atypical antipsychotic to either lithium or valproic acid is better than just monotherapy with a mood stabilizer. Adding lamotrigine to either an antipsychotic, an atypical, or a mood stabilizer, an antiepileptic or lithium is also better. And these agents can be synergistic because we have different mechanisms of action that in monotherapy have shown to do something for either mania or bipolar depression. And then putting them together, having synergistic efficacy targets is rational. And then we need to make sure that there is not this drug-drug interaction that we're adding together two sedating agents or two agitating agents. And here we can mix and match a little bit in order to improve the overall outcome. Also, what's the hepatic metabolism? Is it the same cytochrome P450 system? Then we have to bring down two agents. Or maybe one is renally excreted more than hepatically, and it's actually doing quite nicely. Or with long-acting injectables where you avoid the first pass in the liver. That can be another way of avoiding the drug-drug interaction on a metabolic fashion.
All well said. And you really made me think about something. It's true. I mean, years ago, I was involved in a couple of studies with adding mood stabilizers to antipsychotics for schizophrenia. There were always case reports, but it didn't pan out on average. But yet we have very good data, both for bipolar depression and for bipolar mania, that certain atypical antipsychotics added to either lithium or valproate, or the ones the FDA has accepted, that they can work and can be safe. And you're also right. There was a couple of articles recently that long-term maintenance with both an atypical and a mood stabilizer was actually better than an atypical alone as monotherapy for maintenance. So, that's our goal, is to keep people better. Relapses to be avoided at all costs. Of course, we also have the data on suicide prevention with lithium, and I think lithium is a medication that's probably underutilized in this case. We're not using as much valproic acid for all the reasons that are pretty obvious with the risks. I think lamotrigine has picked up quite a bit, so we tend to see more of that. And the fact is, atypicals are not bad at preventing mania, and lamotrigine is good with depression, so that's a rational combination as well. Also, as you said, when thinking about drug-drug interactions, I always think about pharmacodynamic interactions, and you mentioned additive sedation, for instance. If you're adding two antipsychotics, there's additive D2 kinds of things. And then pharmacokinetic interactions. Do they interfere with each other's metabolism? Are they both metabolized the same way? And so on. Half-lives and things like that. So these are all really important. And I think get into the next thing that we want to, well, before we get into the next thing, I just want to highlight again a little bit more. We don't talk enough about acute treatment versus maintenance and the transition between the two. So what are some kinds of factors to consider in that scenario?
Well, ideally, in the ideal world, we would try to stabilize people acutely with agents that could be taken long term. The problem is that the setting where it happens may not be the same, and the goals in those settings may differ. So, for example, if I am in an inpatient unit, I don't necessarily think long term. I want the patient out in 10 days. This is my mandate. I need to have beds free. So I may take medication or give medications and choose medications that are good now and may have cumulative long-term effects that the patient then may not want to have. And I may give also maybe a higher dose and slam on an anticholinergic to an antipsychotic. We don't want that long-term either, or higher risk of having tardive dyskinesia, lower cognition. So we need to clean up some of this, but patients then come to us with all of these concoctions from the acute phase. So it would be good to identify long-term goals and say, what's important for you? For example, I need good sleep. Okay, then we'll give you something sedating at night. I don't like anxiety. What about EPS akathisia? What about weight gain? And then come up with something that has worked in the past or that could now be a very good combination. I also like the pharmacogenomic quick test, and that is asking the patient, do you have anyone in your family with the same illness? What has worked for them? And what's not good for their side effect profile? Because if they share the disease genes, they may share the genes for response and also for side effects.
That is excellent advice. What a wise clinician you are, Christoph. I completely agree with you. I also ask when I'm screening for bipolar, who do they say you're like in the family? And believe it, because they're not going to be able to tell you, oh yeah, my uncle had manic depression or bipolar disorder. But if I say, who are you like? And they'll tell you, or who in your family had a nervous breakdown is a great term too. Has done that. But I love what you're saying. You're also right. In the inpatient setting also, you can monitor people more closely. So you can be more aggressive with medications. And the fact is, acute mania, you might use a higher dose, as you mentioned earlier. Higher doses for mania and psychosis, lower for depression. So you don't want to set it and forget it, I call it, with your dosing. You want to adapt the dosing to the situation, even over time, long term. So I think that's another thing we don't talk about. Not only the choice of the medicine, but carefully monitoring the dose and being flexible with the dose.
But then also intersecting the medication and symptom goals with the long-term functionality and quality of life goals, because that's ultimately what becomes so important then during the maintenance care. It's not just symptoms anymore, it's the person who wants to function and has certain goals that may differ. Are they interested in self-care? Or their family members around them? Is that the basic? Or do they want to know where they can live and who they can live with? What do they want to be independent? Is it social life with family or even without family? Is it with a partner that they want to have? What about either going back to school or work? And what is needed for that? What degree of stability? What side effects do people not want? And then coming up with a plan. That's not done in one setting and one session. This is something that evolves over time. So there are different stages of the illness, different stages of the treatment, but we need to keep that in mind when designing the treatment plan.
Boy, that is so well said. And of course, you're talking about elements of shared decision-making, incorporating the patient's values and preferences, understanding their lifestyle, their goals. And you're right, that's not something that's obvious right away. I want to focus for a second on sedation. Sedation may be a good thing acutely and in the inpatient setting, of course. And treating mania, you do want to have some degree of sedation, I guess. But over the long term, how would you deal with sedation over the longer term with a patient who's got sedation?
Yeah, so ideally you want to actually have the sedation occur in the evening and as people sleep through the peak. So I usually give, especially sedating, but most medications at night. So in the evening that people sleep through the peak. There's usually in a 24-hour half-life drug, the peak would be during the night, but that might not be sufficient for the patient. They may have a hangover. They may have brain fog that people don't like. And then the question is, can I lower the dose? Do I need to maybe think of a different medication that has similar efficacy, or is it a similar group like an atypical for an atypical that may have less sedation? And I have only targeted sedation in the evening with something shorter half-life that helps people sleep. but that doesn't have this long-term carryover. Again, exercise activity can help people get through the day better and then also sleep better. That's certainly something. You don't want to have too many caffeinated beverages that interfere with good sleep. And then also patients have gained weight often. What about disrupted breathing? What about snoring? They have sleep apnea. So do you want to actually measure for that and then give them CPAP in order to have good oxygen supply during the night, and then they're actually waking up? But if it's not if the medication is it, then maybe you really have to move on to something else. I'm not so much someone who tries to then combat that with modafinil, but even sometimes that may be needed. And a stimulant is tough if there is no ADHD, and we know that in kids, at least, under the shield of an anti-mania medication, you can slowly and carefully introduce a stimulant for ADHD. Maybe in some patients might also help them concentrate better and have less brain fog. But all of this needs to be taken into a discussion with the patient.
Mm-hmm. Yeah, all true. We know that most people with bipolar do have some degree of cognitive issues. So I think a stimulant is certainly reasonable. You're referring to, there's a couple of large data sets from Scandinavia where they showed as long as they are adequately mood stabilized with either a mood stabilizer or appropriate antipsychotic, you can add a stimulant without destabilizing them and may improve mood and cognition and so on. What about this strategy? I just thought of this while you were talking. What about adding a mood stabilizer to your sedating, let's say atypical, allowing you to lower the dose a little bit of the atypical? Is there a synergy there?
Yes, absolutely. You could try to do that, that you have the efficacy signal from 2 and you can lower the dose of the 1. All of this can be played around with, being clear that when symptoms reemerge, either with the patient themselves or maybe also family members, caregivers that are more often involved in people with bipolar disorder than in schizophrenia, that could all help us then design an even better treatment plan, and that patients don't come to us too late and have destabilized.
Yeah, certainly true. We are fortunate in that we have a few different medicines now FDA approved. For, of course, mania, we have many medicines FDA approved. We have some for bipolar depression. There's 5 now. We have a few approved for maintenance. Unfortunately, most of those are only sort of studied or approved as monotherapy, as we talked about. But it occurs to me we still need more options, and sometimes we have to do things off-label. I'm a big fan, Christoph, when you've made a diagnosis, of starting with an FDA-approved medicine, because that means there's at least evidence of efficacy and tolerability. But sometimes we have to color outside the lines and, do
Yes.
other things. So I guess maintenance then can become a challenge. We don't have as much approved or studied. And again, we have far too few studied in combinations. Most trials done for FDA approval are monotherapy or limited polypharmacy, if you will, limited combinations.
Yeah, that's true. But in a way, what puts out the fire or the ashes in acute treatment usually is something that you then should continue if it's tolerated to also stop resurgence of either the fire or the ashes. So maintenance care, unless it's untolerated, you can continue the medication that worked.
Yeah, I think you're right. In general, what gets you better keeps you better. But that's only if patients take the medicine, Christoph. So
yes, very good.
Well, we've got to discuss that. I'm sure most of the clinicians listening will, if I were to ask them, what are your biggest challenges in managing bipolar? I think adherence would be number 1, 2, and/or 3. So what strategies can we use? How should we be assessing and supporting adherence?
I mean, adherence means that people choose the treatments we think are good for them but mostly for their own reasons. And unless we know what their reasons are for selecting or deselecting treatments, we're basically treating where we're not treating the patient, where we're a little bit beyond or beside them. So I think we need to talk openly about we talked about it earlier a little bit, what are the goals that the patient has? What are their wishes, but also their fears? Where are their guardrails? This is definitely something I can't tolerate, whether that's gaining too much weight or having sexual side effects or being brain fogged all day. I need to function. I need to bring in money for the family, whatever it may be. And then we'll say, okay, let's focus on that And we'll work together that this hopefully will be sufficient, and basically we can achieve that goal together for you. But also we need to balance things. So what is maybe the hierarchy? What is most important? Maybe stability is more important than certain things that you may be able to integrate. There's no perfect medication or combination. There's no perfect mother, partner, or job. We all know that. We wish there were. But having the good enough. And what is good enough for one patient may not be good enough for another. We need to know that.
Well said. Do you know what I've learned too, Christoph? Don't assume you know why the patient is not taking the medicine. There are many possible reasons. And I will often do this. I will say to them, look, the fact is, me personally, Christoph, I take a bunch of medicines. I have hypertension, cholesterol, and I can tell you it's not easy to take medicine every day, but especially a psychiatric medicine, which a patient once told me is a daily reminder that I'm crazy. So I like to say to them, look, it's hard to take medicine regularly. How many pills do you think you've missed in the past 2 weeks? You see, I sort of give them an opening to say that, and then not assume I know why, and say, well, help me understand the challenges for you with taking the medicine regularly. Could be a side effect. Could be I don't like how it makes me feel. Could be denial of the illness. Could be cost or access, or who knows? It could be my Aunt Sally is a pharmacist and told me I shouldn't take this medicine. Who knows? And I think so, again, individualizing your approach to adherence is probably also wise.
Absolutely. And I think you made a couple of very important points here. One is to normalize non-adherence. This is something that is part of the human condition. So you can talk to me about it. I don't feel undermined as a physician. You're not doing what I'm telling you to do. So that's why patient may not share it. And then also assuming it's maybe not one, but several reasons. And we want to understand which ones are the most important ones. And patients are not bad patients because they stop or don't want to take medication. So we need to work with them. Ultimately, there is a reason behind it. And people want to feel better. And if they conceptualize something, this is better because medications are mind-altering, or there's a very strong long-term effect that I read up on the internet, and it shrinks brains, or whatever their information from the net might be. Dr. TikTok and other doctors might interfere with what we have not really reviewed with the patient. So asking what you said about the fears and concerns that the patient might have, as well as aspirations and dreams openly, is very important.
Yeah, and this is where medical education and disease education are so important. And I want to put a plug in for an organization, the Depression and Bipolar Support Alliance, that Roger, I know, is on the board, and I understand Rakesh Jana is now also involved with them. And I give the website out, frankly, to everyone because I think it helps with buy-in and with understanding, and it's dbsalliance.org, dbsalliance.org. So I'm a big fan of that as well. I think also it's very important to understand not only the patient's goals and aspirations, but there's a disconnect between us and them in the sense that we are often going for symptom reduction, symptom improvement, whereas for the patient, it's much broader than that. It's quality of life, it's function, it's wellness, right? So I think we need to get more skilled at assessing those things, not just asking them, how are your symptoms, right?
Absolutely. And also taking into account stigma, self-stigma, and the people around them, what they think about the illness and the medication. And as you said, if Aunt Sally says something and is very influential in that family, we may not have a good buy-in from the patient, and we need to address that and maybe bring Aunt Sally in and educate her too.
I love that idea. I love involving family, caregivers, whoever's important. And that's also important, understanding who's important in their life and what are their roles and responsibilities. Are they a caretaker themselves, for instance? What kind of job do they have? What do they like to do for fun, for crying out loud? Does the medicine interfere with that for some reason? Does it cause a tremor, for instance? And I like to play pickleball, and now I can't play pickleball because of the tremor, those kinds of things.
So that means shared decision making means to share the decision with people who make the decision. And it's not only the patient in the room.
Mm-hmm. Yeah, I think also, you mentioned earlier those self-report scales, the MDQ, the RMS. I really like to get a family member or caregiver to also fill those out, or to maybe discuss it with the patient, because sometimes, or I have the patient take a copy home with them, and a couple weeks later they come back and go, now that I think about it, I do have some of those symptoms. Or I discussed this with my wife or partner, and they said, yeah. So it's important there, but also important in the treatment phase, I found sometimes people look better before they feel better, let's just say. And so maybe the patient after 2 weeks will say, well, I don't know that I feel any better. But you ask the partner says, oh, yeah, they are doing better, So that's important.
Yeah, you're making a very important point about measurement-based care. And that measurement can be subjective by the patient. It can be supported by a caregiver. But mood charting can be very important also in terms of the mixed features that we talked about, or the relationship to internal and external events. When you don't sleep, your mood is X. When you are close to your period, maybe that also is a bad time for you and you need to guard against that or take it into account. It's not that the medication doesn't work anymore, just get through those 3 days. So this mood charting might empower patients that they don't feel it's just coming out of the blue. I don't have any control over it. Medications don't work, and then they give up on it. So giving power back to them, but also information to us that can be reviewed.
Boy,
when
that
you miss 2 or 3 doses, then look what happened.
Exactly. That's brilliant. So not only mood charting, but medication charting, I guess, with the mood chart. And nowadays, of course, there are digital tools. There's apps and things that can make that a lot easier than actually, Christoph, when I did the lamotrigine studies, we had paper and pencil mood charts that they filled out. So now we actually have
1800s.
Yeah, it seemed like it was back in the dark ages. But I really love that idea, though, and I really like what you say. A lot of times I will actually show a patient a rating scale or my notes, because sometimes we don't realize where we were at or how bad it was, if you will. And I'll say, look, this is what you told me then. And that sometimes helps with the perspective, because when people start feeling better, they think, oh, well, I'm fine. I don't need the medicine, for instance. So.
Yeah, absolutely. So short of then using a rating scale, I often ask them from 0 to 10. 10 is the worst you felt in terms of where are you now, and I write it down, or in terms of being high. And then they say, I'm not better. Well, they say, well, what are you now? I'm a 6. Well, guess what? Last time you said you were an 8. Oh, really? So I'm maybe better.
That's right. I love that. And so I like quotes too. I will write quotes down and share with them. And also, here's another thing I do. I know a lot of people, we talked about measurement-based care, which you and I are big fans of, but some people are a little intimidated by rating scales. So I say, here, well, create your own. I ask every patient first visit, what are the 3 things that bother you the most? And it can be symptoms, can be quality of life, whatever they are, I write them in the chart. And then every visit, I ask those 3 things. And isn't that measurement-based care just systematically? And then I've created a rating scale that's individualized to them and what's important to them.
Yes, and I love that, Andy, because you're also giving the patient then the feeling, this doctor knows me. He asks exactly my trigger and pressure points. And we can do the other way around too. What are the symptoms that usually indicate that you're getting depressed? For some, it's not calling their friend anymore. Another one, I don't want to walk the dog. I'm only going out 5 minutes, so that you can ask about these things. The next one is, I don't sleep for 2 days. Yeah, so having these individualized trigger points and also goals makes it for a much better interaction, even if you have short periods of time with the patient.
You're so right. And also giving a family member or a caregiver, an important person, getting them to understand those clues so they can recognize. And very often the canary in the coal mine, as you said, is change in sleep. But let me tell you a quick story about one. Years ago, I had a husband and wife, and the wife had bipolar. Her husband said, I can always tell when she's going into mania. And this woman was rather drab looking. I mean, just, dressed kind of plain drab looking. He said, she'll start wearing a canary yellow outfit, and she'll buy a pack of cigarettes. And when I see that, I know it's coming and I'm in trouble. That's a very specific example, but you know what I mean. Getting them to understand both the patient and the family. And sometimes I even give them permission, Christoph, to adjust the medicine in some way when that's happening, not to have to wait to see me or come in. So for instance, if they're taking a sedating medicine, maybe raise the dose, or if there's an adjunctive medicine they can use. Yeah.
I love that, Andy, because you want to empower patients in between visits.
Yes, that's exactly it. That's exactly well said. And that fits in the theme of what we're talking about, of shared decision-making and giving people a sense of control over this. This is not just passively doing what I tell you. And I think outcomes are obviously going to be better and adherence is going to be better. We talked a little bit about comorbidities. I don't know that we talked about psychopharmacology strategies. And We didn't talk about substance abuse, and let's face it, that's the elephant in the living room because that's one of the most common comorbidities. How do we deal with substance abuse here? How can we incorporate that into our thinking?
Well, again, you need to ask about it and be open, have that patients realize that we realize that this is common, that is often an attempt of feeling better, self-medication, and that it's not always under their control, might fluctuate with the mood states itself, and we want to understand that. And then there are treatments that are like group Alcoholics or Narcotics Anonymous, or we want to have also some CBT treatment, group treatment in order to help patients get away from it. But once you stabilize the mood, that often can also successively reduce the substance use. But on the other end, I mean, you need to sometimes reduce substance use in order to improve the mood too. Yeah,
that's right.
It can be complex.
That's really well said. And I find one of the best treatments is effectively treating the underlying mood disorder, if you will.
Yeah.
I also, just like I have non-judgmental conversations around adherence, I have non-judgmental conversations around substance abuse. And I'll say, let's face it, you're probably trying to self-medicate this condition you have, but you're doing it inefficiently, I'll say. You're using something that goes up and down really quickly. And here we have something maybe that'll be a little more efficient. And of course, it's legal. And there probably are, let's face it, this is inadequately studied, but we probably have some treatments that are more effective than others at both treating the mood disorder and maybe treating the substance abuse, right?
Yes, I mean, we know, but that's not always an option or very rarely an option for bipolar disorder. Clozapine seems to have some specific role for reducing substance use and craving, but even olanzapine has been shown to be quite helpful. Maybe it has some clozapine-like effects there, structurally they're related. Also, maybe agents that are anti-anxiety drugs, because people are not only taking drugs because of mood disorders, they might actually treat anxiety and social anxiety.
That is beautifully said. I think we need to look for that exactly, those anxiety conditions. Cariprazine, in my experience, with its D3 effects, agonism, effects on motivation reward, anhedonia, for instance. So what we're really saying, I guess, Christoph, is we probably need to understand better what it is they're trying to self-medicate. Is it more of a dopamine anhedonia issue? Is it an anxiety issue, for instance? That's a good
Or is
point.
it driven by mania that then the substance use happens, and once you curb the mania, it won't happen anymore?
Yes.
Yeah.
It's funny you say that. I vividly remember a patient I had who was a former Navy SEAL, business owner, real citizen, but periodically he went off his valproate, he got manic, and he would end up in a part of town we called Cracktown, and he would be buying and selling drugs. And so that's a really good point about that effectively treating the bipolar would have kept him out of Cracktown, if you will. Yeah. Well, Christoph, I have to tell you, this is such a fascinating conversation. It's always fun talking with you. I learn all the time, and hopefully we stimulated each other to come up with some things that will be helpful to our audience. I guess I'd like to just ask, do you have any final thoughts or final words here on the topic we're talking about, which is, of course, the complexity and personalizing our treatment for bipolar?
Yeah, I think you mentioned it in your question. To acknowledge this is a very complex disease. It's hard to manage because you have to treat and prevent the ups and the downs, many comorbidities, physical and psychiatric, to remain humble, but also open toward trying to improve outcomes, because different from some patients with schizophrenia where it's really very hard and we have only one class of medication available. Now we have maybe a second one, but converging on dopamine reduction in certain areas of the brain. We have really multiple mechanisms of action here that can be leveraged and put together. And trying to experiment with the patient, find out from the past, and also be open to not settle for copper, but go for silver at least. Even if it can't be always gold. I think that's something. Stay hopeful with the patient and also target functioning and then work your way backwards into what treatments can get you there.
Yeah, so perfect is the enemy of good enough, if you will.
Yes.
But I really like something else you said. You know, some of this is inspiring hope and is giving patients realistic prognosis. In other words, having a diagnosis of bipolar disorder in no way is a death sentence. Actually, with appropriate treatment, you can live a very normal, full life. And as we know, there are associations of bipolar with even genius and creativity, which we'll be talking about at the Congress, NEI Congress this year. I really love what you said about the complexity, and I think we have to be humble and also to individualize. There is no classic presentation of bipolar disorder, as you know. It's a very heterogeneous illness in the way it presents clinically, both the symptoms of the bipolar, also the comorbidities. And of course, we're learning more and more about the heterogeneity neurobiologically, and hopefully that will lead to more sophisticated treatments. Well, Christoph, I'm staying tuned, and I'm revitalized at this stage of my career. I know you are too. We're going to keep doing this for a little bit longer, and we hope you have enjoyed listening. Yes. So thank you for joining me, Christoph.
Thanks, Andy. This was a fascinating and very fun conversation. We hope that the audience will also take something out of it. And see you at the NEI meeting very soon.
Yes, we'll see you very soon. And for you listening, if you'd like to hear any more of our podcasts, you can get the podcast wherever you get podcasts. You go for NEI Psychopharm. For more information on our meetings and our other products, you can go to our website, which is neiglobal.com. So thank you very much for listening, and take care.
Thank you for your participation in this CME NEI podcast episode. To receive your certificate of CME credit, please refer to this podcast's description page for a link to print your certificate. This concludes the CME podcast presentation. For more information about NEI and our premier educational content, please visit neiglobal.com.